Welcome to yet another interesting episode of the Health Package Field Program Community Health. With me, your regular host, Hasia Ali. Today in the studio, we have Dr. Momoh Abdulhamid Omaiza from the Department of Internal Medicine, Ahmadu Bello University Teaching Hospital, Shika, Zaria. Dr. Abdulhamid is a member of Association of Resident Doctors, also from Ahmadu Bello University Teaching Hospital, Shika, Zaria. We say a very warm welcome to you, Dr. Abdulhamid.
Yeah, thank you very much.
You're most welcome. All right, listeners, today Dr. Abdulhamid will be talking to us about heart failure. Well, a lot of us know people die of heart failure, but let's know what heart failure is. So, Dr. Abdulhamid, what is heart failure?
Well, thank you very much for giving me the audience actually enlightening you and also the society at large about heart failure itself. Well, I can't talk about heart failure without talking about what the heart is as an organ itself. The heart is actually one of the most important organs in the body. In fact, if not the most important, but it's one of the most important because there are a lot of organs in the body and they're all equally important. Heart, it's very important because it's the one that supplies blood to every part of the body.
Okay.
The brain, the kidneys, the liver, in fact, virtually everywhere. And even the skin itself, is the heart that supplies blood to every part of it. And the heart has 4 chambers. We have the left ventricle. We have the right atrium and the right ventricle. There's a side that gets blood that doesn't have oxygen.
Okay.
The side that gets blood that has oxygen. So we have the right side and the left side of the heart. The right side gets blood that is not oxygenated. That is from the body.
Okay.
It gets blood that is not oxygenated from the body. Then it goes to the right atrium, then to the right ventricle. That is blood that doesn't have oxygen. Then that one will now go to the lungs. In the lungs, that's where we breathe in oxygen. So the oxygen now enters the blood in the lungs. Then now it comes back to the left ventricle.
Wow.
That's the left side of the heart.
Okay.
So that side is the one that now pumps to the other part of the body. So essentially, the one that don't have oxygen comes from the right side, gets to the heart. The heart pumps to the lungs. Lungs gives the oxygen to the blood. Takes it back to the heart. Heart now pumps to the body. So it's when the heart can't meet its demand that's what we call heart failure. In standard definition, they said it is when the heart cannot meet the metabolic demand for the body despite adequate feelings.
Okay.
That is heart failure. Because heart failure can actually occur in patients who have accidental heart blood loss. That is because there's no blood to come to the heart. That is why the heart is having issues.
So
but this one
something would have stopped the blood from going to the
But
heart.
this one, blood is coming, but the heart cannot meet the demand of the body again because there's an issue with the heart itself.
Wow.
So that is essentially how I'll classify, how I'll talk about heart failure, the definition itself.
So, you just enlightened me and the listeners, because a lot of us know that, yes, the heart pumps oxygen. I think a lot of us do not know that there's a part that actually doesn't pump the oxygen.
Exactly. I think the misconception is the heart, it just pumps blood. That is the one thing. It's the lungs that gives the oxygen.
Okay.
So we breathe in oxygen, breathe out carbon dioxide. The oxygen you're breathing is going to the lungs, essentially.
Oh, okay.
Not to the heart.
Not to the heart at all.
What the heart does is that when it gets the blood that doesn't have oxygen from the other part of the body, it takes it to the lungs. So like lungs give it oxygen. When lungs are giving oxygen, the blood now comes back to the heart again.
Okay.
Then that one that's coming back to the heart has oxygen. Then the heart says, okay, this one is okay for the body. Let's now get it to the kidneys, to the brain, the part of the body that this one has oxygen, and to now help the other organs do their functions adequately. So that is just essentially. There's always a misconception with the heart that people tend to have. People attribute oxygen. In fact, a lot of functions of the heart, but essentially it's just pumping of
blood.
So
okay, but it's not responsible for the red blood, the white blood.
No, it's not. It's just in fact it's just the blood
generally blood.
Yes, supplied to the body.
All right. Having explained what the heart is and talked about heart failure, now let's look at what are the causes of heart failure.
Yeah, generally in our environment, I would pick our environment because this is where we are. The common cause of heart failure in Africa generally is people who have hypertension for a long time. As they call it hypertrophic, they call it hypertensive heart failure.
Okay.
They've had hypertension for a long time, maybe spanning for 10 to 15 or 20 years. And what hypertension means is that the heart is pumping at a higher pressure than it should be pumping.
Okay.
That is why you get 140/90. That is, the pressure from the heart is above what it should be.
Normal.
Normally it's 120, 110, 120, 70, 80, ideally. You understand? It's 60 to 80 for diastolic. But once you're having, that pressure is the pressure of the heart, of the heart itself. So once you have hypertension, it means the pressure has increased in the heart. That means there is something making the heart to pump against high resistance. So there is that's what we call hypertension, high tension. You understand? So there is increased tension in the heart. That is why people who have hypertension for a long time, after a long time, the heart feels like, I can't do this anymore because I've been pumping for a long time at a higher pressure. If I'm supposed to pump, if I'm doing that at normal pressure, I'll have lasted longer than this. But I'm doing at a higher pressure, so at a long time, at a very long time, it tells you.
So that's you've overstressed the heart.
Exactly.
Okay.
Yes, I'm tired, and before you know, you can't pump the blood again to the other body. You're just having the symptoms of heart failure itself.
So now, having said hypertension could cause a heart failure, what about those who have low blood pressure? It doesn't cause a problem to the heart.
It's just hypertension.
Okay, just basically hypertension. Okay, what are the other causes of?
Yes, other causes that we have in the environment. A patient can have also congenital heart disease itself. Okay. Congenital heart disease, people who have issues right from birth with the heart. Maybe when they were inside, there's some issues in utero, that's inside the womb. Okay. So when they came out, instead of the heart having 4 chambers, having 2.
Wow.
You understand? Wow. So those ones, right from onset, right from birth, childhood, they have issues with the heart. They have the symptoms already. Symptoms that should be happening in the elderly people, they're already having it at the childhood. So that means they already have congenital heart disease itself. Another cause is also people who have a patient who has, let's say, myocardial infarction, like MI.
Okay.
MI means there is cut of blood supply to a particular part of the heart. You understand? Once you have that, it makes you at risk of having heart failure, because once that area of the heart is not longer supplied by blood. Because what happens is MI is myocardial infarction, meaning that part of the heart, as the blood is coming, as the heart pumps to every part of the body, it's also pumping to itself too,
okay.
Yes. So because
it also needs the blood to survive.
Exactly, oxygen too. So if there's a part of the heart that there is blockage, and that means the blood is not getting to that part anymore, that means MI. That's how the heart will die. Okay. So when the heart is pumping normally, that side already dead. So there won't be adequate contraction from the whole heart itself.
Okay.
You understand? So another common cause is patients who have valvular heart disease. Valvular heart disease means they have issues with the valve.
Okay.
Valves in the heart, we have valves in the heart. Just as I said before, we have left side, right side.
Right side.
We have right atrium, right ventricle. Between the right atrium and right ventricle, we have a valve there.
There's a valve there, okay.
Between the left atrium and left ventricle, we have a valve also. Between the left and the aorta, there's another valve. Between the right and the pulmonary vessel, there's another valve. So pulmonary vessels essentially are the ones that supply the lungs.
Okay.
When the blood comes to the right side, it goes through the pulmonary vessel to the lungs. As coming back, it comes back to the pulmonary veins to the heart. So the heart now pumps to the aorta. Aorta is one that goes to the other part of the body. You understand? So there are 2 kinds of blood. We have blood without oxygen, blood with oxygen.
Blood without
oxygen.
Oxygen.
They call it deoxygenated blood.
Okay.
Then we have the one that's oxygenated.
Okay.
Yes. What the body needs is the one that has oxygen.
Okay.
That's what the body needs generally. Even the kidneys, all organs need oxygen to metabolize everything they have. Once the blood comes, the one that does not have oxygen comes to the heart, it goes to the right side. First of all, enter the right atrium. From the right atrium to the right ventricle, there is a valve there. They call it tricuspid valve. Okay. Tricuspid. Once the blood gets to the right ventricle now contracts and pumps to the pulmonary artery, to the lungs. In the lungs now, the lungs has oxygen a lot, so you now give the blood oxygen. And after it starts finishing oxygen, the blood now comes back to the pulmonary veins, to the left ventricle. Okay. From the left ventricle now, the blood left side of the heart has oxygen, fully has oxygen. So from the left side, it now goes to the aorta. Aorta now supplies every part, both the kidneys, the brain, the liver, everywhere. So once those valves in either side, either the right side, the left side, or the pulmonary side, or the aortic side has any issue, it can also lead to heart failure for a long time. Yeah. So, in fact, there's also called dilated cardiomyopathy. Okay. That is heart muscle disease that leads to the heart being extra large. Okay. That's what they call dilated. Dilated means big.
Expanding.
Exactly. So, because it's big, it is now thin. It can't meet that pressure that it should supply every part of the body. That's what they call DCM, dilated cardiomyopathy. There are a lot of cardiomyopathies. We have DCM, we have constrictive, and we have restrictive. Okay. We have DCM, we have constrictive cardiomyopathy. You understand? So, then we now have hypertrophic cardiomyopathy. The dilated is one cardiomyopathy. Hypertrophic is another one. Then we have restrictive cardiomyopathy. These are the 3 types of cardiomyopathy we have. You understand? So those ones can also lead to heart failure. So, but commonly in our environment, patients who have hypertension, they are the ones that are the commonest one for a long time. Sometimes heart failure. Patients who have rheumatic valvular heart disease, that's a disease of the valve. Those valves also come down heart failure. Patients who have congenital heart disease too. People who had MI before when they had also a risk of heart failure itself. Then other cardiomyopathies would come into play.
So while you were discussing about the heart diseases, what could lead to failures, you said a baby born with 2 sides of the heart instead of 4. When a child is born like that, is it detected at birth and is managed, or sometimes you don't even know that a child is born with such condition?
Well, there are different types.
Okay.
There are some that in fact, some child can't even survive. In some, for example, that's what they call transposition of gate vessels. But what it means is that instead of the aorta taking blood that it has oxygen, it's not taking the one that is not oxygen, that does not have oxygen to the part of the body. Do you understand? You know, aorta takes oxygenated blood to the part of the body.
Yes.
But in those ones, there is what they call transposition. That's the exchange. The aorta is now the one taking the blood that doesn't have oxygen to the part of the body.
Okay.
And the pulmonary vessels that you take the one without oxygen to the lungs, are not taking the one with oxygen to the lungs.
Okay.
And the lung, that means
the jobs are being switched.
Exactly.
Okay.
Those ones, there's less likelihood of having survival. Having less likelihood of surviving actually.
Okay.
Then there are some other ones that have lesser effect. There's one we call ASD. ASD is atrial septal defect. That is the defect is in the atrium. The ventricles are normal.
Okay.
You understand? So those ones they can be normal even at the early childhood till maybe that kind 7, 8 years after having symptoms. You understand? Then you can also have what we call VSD, ventricular septal defect. You understand? There are a lot of congenital heart diseases, but most of them are picked in the early childhood. Some stay longer before you have this because they have lesser effect on the heart than others. But some child doesn't even survive at all.
Then for those the adults who could have been from the hypertension, is it known hypertension? Or, some people actually have high blood pressure and they don't even know.
Yes.
So, do you easily find heart failures from those who have known hypertension or those who don't even know they have hypertension?
Well, I've seen a lot of patients that the first time they're coming with hypertension is heart failure.
Okay, so they're not even aware.
They don't know. They come down with heart failure. Then from there on, pick that. You have the signs of long-sign hypertension because there are some signs that we check for that we see and that okay, this patient has long-sign hypertension. There's no way. Probably he didn't know, and no hypertension is silent killer. No symptoms. You're just there living your life, but it's affecting the heart because the heart actually fights. It actually helps. It actually, how can I say it now? Tries to adapt to that type. So you will not even feel it as a person that there's something going on because the heart is trying to modify itself to meet the demands of the body. But essentially, if you have some patient comes first time with heart failure, and that's when they actually know that they're hypertensive. Then there are some that have been controlled for a long time, maybe 20 years, 20 to 15 to 20 years, to come out with heart failure, essentially. Yes.
All right, having talked so much about the causes, now let's look at the types of heart failures that we have.
Okay. I will make it simple. We have, before there used to be classification I call it that they classify into systolic heart failure and diastolic heart failure. Okay. Because there are two stages. The heart contracts. There are two stages of contraction. The first is systolic. Second is diastolic. Systolic is when the heart contracts. Diastolic is when it relaxes. And that's why you have blood pressure. We have two. Up and down. The one up is systolic blood pressure. That's when the heart is contracting. Okay. And when it's relaxing, is the one that's down. Diastolic blood pressure. So before it used to be diastolic heart failure, systolic heart failure. But now they've changed the term. Okay. Yeah, it's now heart failure with preserved ejection fraction.
Preserved ejection fraction.
Ejection fraction. Okay. Or heart failure with low ejection fraction. Okay. Meaning, despite the fact that the heart is failing, it can still pump above 50% of the ejection fraction. Required, okay. Yes, for the heart. But in people who have heart failure with preserved ejection fraction, the heart is failing, but the supply to the heart, to the other part of the body is still above 50%. Okay. But then the one with heart failure with low ejection fraction means those ones, the ejection fraction is less than 50. There are some with some 35%. That means 35% means 35 or 100. 100, yes. Understand? So there are some with preserved, there are some with low ejection fraction. Preserved means the ejection fraction is still above 50, while the low is less than 50%. Essentially. So people use 45% as their cutoff, but 50, 45 essentially. Exactly. Yes. Thank you.
Now, let's look at the signs and symptoms. Obviously, there will be signs that will start telling you that, okay, there's a problem. What are the signs and symptoms?
Well, if this were to be a clinical scenario, I would have given you a criteria they call major and minor criteria for heart failure, for diagnosis of heart failure itself. Failures, okay. But symptoms generally that we have is if a patient, for example, one has a risk factor for heart failure. Okay. Risk factor means patient has hypertension, or has congenital heart disease, or has valvular heart disease, or MI, anything that's like a risk factor for heart failure itself. So they can come down with maybe after they walk for a long distance, they sit down to breathe fast, like they are tired, like they start breathing very fast. That they call it difficulty in breathing on exertion. That is, you walk small, you feel like, "Ah, boy, why am I breathing this fast?" And you start having swelling from the legs, having body swelling, because you know what happens is all this fluid are supposed to come back to the heart, if I pump everything, but because the heart can't meet, yes, it just stays in the leg and stays there. So they call it bilateral leg swelling. We call it pedal edema. So another thing they can also have is they can be coughing. They can have cough. What happens is once the heart can't meet pump all this blood supply, some actually reside in the lungs too. And that classical symptoms they have is the fact that, in fact, that cough sometimes it's productive of sputum. It's more of frothy, like the sputum will be foamy.
Oh, okay.
It's foamy. Sometimes it can be a blood thing. You can see blood inside. Mostly they have difficulty breathing on exertion, on mild to moderate exertion. They have leg swelling. They can have leg swelling up to the abdomen itself. They can also have cough. They can have what they call PND or autopnea. PND means autopnea essentially is that the patient cannot even lie down flat. You
ask lying down flat on your back?
Back, yes. Okay. Like they will need pillow to be able to. In fact, sometimes when they come to the hospital, you ask them, how many pillows you used to sleep on? They say like 3 or 4, meaning patient cannot lie down flat. They need to lie down a bit erect to feel better. Understand? There's PND. They call it PND means paroxysmal nocturnal dyspnea. That is, nocturnal means night. Dyspnea means difficulty in breathing. Okay. They just wake up at night, they start breathing very fast. After lying down flat for some time, they just wake up and start finding difficult to catch their breath. That is PND. It's a major sign for heart failure itself. Then there are other features like you can't eat well, you have you eat small, you feel full, you are anorexic, if you don't feel like eating, you just feel generally weak, and you can have other infections that can cohabit with even the heart failure itself. Maybe chest infection, you can have UTI. UTI means urinary tract infection essentially. But commonly in the environment, what they come with is cough, difficulty in breathing, and leg swelling. Yeah.
Okay, now you talked about this leg swelling. It's as a result of collection of fluid in the legs. Is there anything particularly that causes that collection that makes it not pump to the heart?
What happens essentially, it's every part every part of the body has what is going on, like the limbs, the kidneys, the liver, the brain. They all have blood supply to them essentially, and the limbs, lower limbs especially, have veins that bring the blood back to the heart. So once the blood that's supposed to come back to the heart, it comes because the heart can no longer meet that demand. It can't pump efficiently. Okay. You understand? And sometimes it can't even feel well. That is, it cannot feel to be able to meet, like as it comes, maybe it just feels small and it can't go further. So the remnant that ideally should come in, to just go back and go in the limbs essentially. They call it the dependent areas. You understand? That area is against gravity itself, so it just goes down and stays in the limbs. That's called pedal edema. And as it worsens, it progresses
going
upwards. In fact, some people tend to have it up to the stomach, to the abdomen itself. Distension.
Wow. Well, now let's look at the diagnosis. What are the diagnoses for the heart failure?
Well, diagnosis essentially it's clinical and laboratory. So for clinical, when we see a patient with heart failure, there are some symptoms we ask for. That's called Framingham criteria. Okay. It's actually a medical term for diagnosing heart failure clinically. Okay. There's a major and a minor. Okay. For the major criteria now, a patient who has PND, I've already explained to what PND means. Yeah, it's a sign of patient is also like sign of heart failure. It's a patient who has what they call central venous pressure. That is, actually that one is more objective. They measure the pressure above about 16 cm of water. Okay. Then patient who also has raised GVP. That is, there's a neck vein because of the fact that the heart can't feel properly. The blood engorge. They tend to engorge at the neck veins here. So you have raised GVP. Then you can also have patient can also tend to have acute pulmonary edema. They tend to have pulmonary congestion in the lungs, like there's fluid in the lungs itself. So then another thing they can also have is they can also have they can also have, for minor now, let's say minor. They can have bilateral ankle edema. That's where the edema comes in, swelling comes in.
Okay.
They can also nocturnal coughing at night. They can also have that. Then they can also have a patient can also tend to have major and minor. For the minor, bilateral ankle edema, we have bilateral ankle edema. We have nocturnal cough. We also have hepatojugular reflux. We have patients who have weight loss of less than 4.5 kg on treatment.
Okay.
The diagnosis essentially is either clinically or laboratory.
Okay.
Clinically, we have Framingham criteria, which is major and the minor. For the major criteria, you have two majors. It's actually diagnostic of heart failure, or we have one major, two minor diagnosis of heart failure. For the major one, I've talked about. But if you now have that weight loss is less than 4.5 kg on treatment, it's minor.
It's minor, okay.
You understand? For major, once is above that 4.5 kg.
4.5.
That means that is
for minor is less than
4.5. That means you're not getting that exact weight loss, but it's close to. That is minor. So when you have
just a range,
yes, when you have two major and you have just two major diagnostic. Okay. But if you have one major plus two minor. Example: patient who has PND, then now has bilateral ankle edema, then now has nocturnal cough. That's already two minor. Two minor plus one major is clinically diagnostic of heart failure itself. Then for laboratory wise, we do chest X-ray, ECG, and echo.
Okay.
Echocardiography. On chest X-ray, you can see the patient can have pleural effusion. That's fluid. You see the fluid in the lungs itself. Okay. You can see cardiomegaly. Cardiomegaly is big heart on the X-ray. You can also see there's what they call air lobe diversion. Air lobe diversion on the X-ray. That one is what you see on the X-ray. So essentially, there's what they call there's also essentially after you see the cardiomegaly, you see the pleural effusion, you see air lobe diversion, and you see. Let me just feed that down. Then for the ECG essentially, there are a lot of things you see. Patient who has long-term hypertension, you see it on ECG. There are some things you check for in ECG. You see them. You see left ventricular hypertrophy on ECG. You see patient can have like tachycardia on ECG. That's increased heart rate on ECG. Okay. Then patient can also can have signs of that's what they call left atrial enlargement, left atrium or the right atrium. Then on echo, it's echo that tells you there's heart failure. It's on echo. Echo is like a video. It's like a scan of the heart itself. Shows you what's going on in the heart. That's where you actually get that EF from. EF is ejection fraction. That's where you actually get it from. Once the person doing it gets that ejection fraction, you can now say whether it is preserved ejection fraction, heart failure with preserved ejection, or heart failure with reduced ejection fraction. So on echo, you see valvular abnormalities on echo. You see wall abnormalities on echo. You also see the ejection fraction on echo. So essentially, that is when there are other investigations you do. Full blood count, differential, if there's any infection, EUCR. EUCR is done to check. EUCR means urea, erythroid, and creatinine, to check for kidney functions. Then you can also do LFTs for liver function test. Then you can also do the full blood count essentially is to check whether there's anemia or there is ongoing infection in the patient. Then you can do urinalysis, urine MC. Those ones are just general investigations you do for the patient. So diagnosis generally is clinical and laboratory.
Okay. Yeah. Now let's look at are there preventive measures for heart failure?
Well, preventive measures still broad based on based on primary prevention. That is a patient who has, like for example now, a patient who has no risk factor is because you can actually have, for example now you can have an MI. Okay. You can be living your life normally, then suddenly you have an MI. That MI alone puts you at risk of heart failure itself. You understand? But essentially, prevention generally is just if you don't have any of these risk factors, regular exercise, good dieting, and also regular checkups, so as to know, because nobody knows when it comes and so happens. Regular checkup. But if you have the risk factors like hypertension, diabetes, congenital heart disease, rheumatic valvular heart disease, essentially, you already have a risk factor. So you now have to prevent. First thing is going to the hospital, so they will do necessary investigation and know exactly where you are, at the level you are. then give medications. If it's hypertension, give medications that will control the hypertension, and also they would advise you on both dietary and the pharmacology therapy. Dietary means the ones that you avoid salt and eat less fatty food and the likes. For the medications are the ones you take drugs. Yeah, essentially. But essentially it's just once you have symptoms, present early. Because early diagnosis is key.
It's key.
Yes. So that's just because you have a risk factor, you go to the hospital early. There's anything, go for regular checkups, use medications well, and go for follow-ups in the hospital, essentially.
Okay, thank you so much, Dr. Abdulhamid. Now, before we go, let's look at the treatment modalities.
Yeah. For treatment, essentially, in medicine, there are treatments that they are what they call treatment for the symptoms, and treatment that helps
manage it.
That helps to reduce mortality.
Okay.
You understand? They are the ones that help with the symptoms, just like they just make you feel better, but they don't actually help with reducing mortality. There are some that help you with reducing mortality itself. You understand? For treatment now we have non-pharmacological and pharmacological treatment. Non-pharmacological means the normal, before we go for the drugs, the ones that without the drugs essentially. That is where the whole thing comes in. Salt diet, works with salt diet, avoid serious exercises. Not like you can do exercise, but avoid serious exercises. Then you're good if you should also have regular checkups to hospital. If there's any symptoms, go to hospital early, go for routine follow-ups. Because essentially the thing we have in Africa is most people don't really feel like checkups, even if it's twice annually. Just make sure you know about your body status. Yes, essentially. So once you do that, honestly, at least your mind is at rest. If there's anything going on, you will know essentially. So another thing also, it's for the drug therapy itself. There are some that relieves the symptoms, especially the ones that if you come with emergencies, like you have pulmonary edema, as you have fluid in your chest. There are some drugs we give. They call them diuretics. Diuretics are drugs that helps you to pass more urine. Those fluid you have in your body will not stay. You pass them, then you feel better. You feel relief. There are some that help to increase the heart rate itself. There are drugs that increase the heart rate. Then there are drugs that increase the heartbeat essentially. That makes the heart to beat better. That increase contractility of the heart. So there are also drugs that helps to reduce mortality. That's when we'll talk about ACE inhibitors. Then beta blockers, and then spironolactone. Since there are drugs that improve symptoms, and there are drugs that reduce mortality in patients. An example of those that reduce mortality is the beta blockers, ACE inhibitors or ARBs. Then the ones that improve symptoms are the furosemide, the diuretics, the digoxin, and every other one. They improve the symptoms of the patient essentially. So.
All right, thank you so much. Listeners, we've been talking to Dr. Momoh Abdulhamid Omaiza from the Department of Internal Medicine, Ahmadu Bello University Teaching Hospital, Shikazara. But we'll not let him go until he gives us a final advice on heart failure. Please, doctor, advise our listeners on heart failure.
Well, my advice will still be attributed to the fact that know our bodies and our health, essentially. We have to know where we are. So if I would advise listeners to always go for checkup, even if it's twice annually, and honestly, it makes you feel at calm and at rest. And you know that you know your system, you know what's going on. Because hypertension is actually a silent killer. Nobody knows who's hypertensive or not. A lot of people walking around don't even have hypertension.
Until they fall.
So essentially, routine checkup is important. And also, if you have any symptoms, please, early diagnosis is also key.
All right, thank you so much, Dr. Abdulhamid. Listeners, it's been Dr. Momoh Abdulhamid Omaiza from the Department of Internal Medicine, Ahmadu Bello University Teaching Hospital, Shika Zaria. Dr. Abdulhamid is a member of Association of Resident Doctors, and he's talked about heart failure. Thank you, Dr. Abdulhamid, for coming.
Thank you very much, ma'am.
Listeners, join us same time, same station next week for yet another interesting episode of the program Community Health. I remain your host, Hasia Ali, saying goodbye.